virulence of the bacteria, and the ability of one's immunity to fight the infection. So, how do one develop TB? When a person is exposed to Mycobacterium tuberculosis, it may develop TB in 2 stages. 1, the infectious stage, and 2, the disease stage. So the infectious stage occurs when the bacilli enters the body and stays within the tissue. But when the person becomes ill because of significant effects of the bacilli, the patient develops the TB disease. So what affects the rate of progression from infection disease? It can occur at any time. It may take days, months, years, decades, even after the patient's initial encounter with the disease. But the greatest is soon after infection, especially in children. Other factors that triggers the rapid progression from infectious to disease stage. That's when we have physical stresses, malnutrition, decreased immunity, especially people who have HIV, those who are on steroids, toxic drugs, diabetes, alcoholism, and drug abuse. A third of all HIV patients have TB. So by way of pathophysiology, in primary tuberculosis, it describes the first infection with TB. Once inhaled into the lung, the alveolar macrophages, they ingest the bacteria, and the bacteria then proliferates inside the macrophages and cause a release in the cytokine, chemoattractants, and cytokine, resulting in inflammatory cells reaching the lungs, draining hilar lymph nodes. The macrophages presents the antigen to the T lymphocytes with the development of a cellular immune response. A delayed hypersensitivity reaction occurs, resulting in necrosis and formation of a granulomatous disease. After this initial phase, TB can go through 2 stages, whether it goes through the latent phase or the reactivation phase. And so with secondary TB, it occurs in the disease in a patient who had prior infection to the disease. It usually occurs in an adult, the result of either a reinfection or reactivation. But I realize that reactivation is more common, and the most common site is the apex of the lungs, typically seen on X-rays as apical cavitation. These are some of the symptoms we encounter when we see patients with TB: drenching night sweats, fever, chills, fatigue or weakness, weight loss, loss of appetite, hemoptysis, chest pain, cough lasting longer than 3 weeks. So this slide just subdivides the symptoms that patients present with into respiratory symptoms and general symptoms. So the respiratory symptoms, they cough for more than 2 weeks. They come with, that's sometimes productive. They come with hemoptysis, chest pain, breathlessness, and frequent colds. The general symptoms that they come with weight loss, fever, night sweats, tiredness and lethargy, and loss of appetite. Physical examination. When you're examining them, you realize that these patients, they look obviously ill. They may be pale, they have fever, weight loss, tachycardia, and lymphadenopathy. The initial stages of pulmonary TB, when they come and we are assessing them, you might not even find any abnormal respiratory symptoms. As the disease state progresses, you find fine crepitations, bronchial breath sounds, dull percussion notes, and localized wheeze. Investigations of TB. Years back, when we are talking about investigations of TB, we would have said the slide perfectly sums up how TB is being investigated by way of diagnostic investigations. I realized that there's been so much gap, especially when we're talking about the epidemiology. I realized that so many of the cases that were notifiable, but when we did the investigations, we realized that either time was lagging or we couldn't really confirm the disease. And so much effort has been put in getting newer ways of diagnosing the disease that will help eradicate the disease by 2030, which is in line with WHO's SDG goals. And so the gold standard for tuberculosis remains culture of the medium, but we have issues with it because it takes a longer time for us to get culture results. At first, the initial step used to be sputum microscopy, but as we go on, we realize that there are newer techniques that you can use the initial assessment of somebody who has TB. Because direct microscopy, one, it is insensitive and it's operator dependent. You need to have a typical positive result, you need about 5,000 to 10,000 organisms to be present in order to get TB. So we still dwell on imaging. So the chest X-ray, but there's been an improved form of it. Then CT scan, then also the newer guys on the block. That's the nucleic acid amplification test. That's what we nowadays we mostly dwell on to diagnose TB. So here's a typical example of a chest X-ray. On the left of your screen, you find a normal orthodox chest X-ray that we do for people with TB. But now we've found newer ways of evaluating TB using the computer-aided detection for TB. Simply put, CAT4. That's an image of it seen on the right of your screen. And so what happens is that once the image is taken, it's connected to an automated machine that scans, it has a database that scans through from normal chest X-ray to pathological chest X-ray as well. And so what it does is that it highlights points of abnormalities within the chest X-ray in order to help diagnosis. And together with the patient symptoms that they are presenting with, a score of between 0 to 100 is made. If the score is greater or close to 100, then a presumptive positive test that is indicated for further investigation is insinuated. And so this is helpful in areas where, one, you can't find a ready clinician to be able to go through all the X-rays as well. And two, when you find that you have technology that's lacking, like in GeneSpec, that takes so much time, about 4 hours, to review just one cases, and you are going to screen a whole lot of people. This is a good screening tool and technique in order to help you to differentiate those who need further management and those who don't, based on what the patients, based on the score in which they present with. Like I said earlier, there are newer ways of finding, or there are newer ways of detecting TB. And so WHO has recommended the test. WHO recommended tests have also been organized to clearly delineate the intended use as per the recommendation for the Model 3, the 2021 update. So the new organizational structure is one, the initial testing of the TB and the follow-on diagnostic test. The initial test can either be done with drug-resistant detection or without drug-resistant detection. And so these are broadly classified as WHO-approved rapid diagnostic tests. And in short, they can sometimes call it MWRDS. So these are the newer classes of technology that is being employed in the early detection of TB. And so these technological classes and now the product that has been approved so far by the WHO is in this table. The classes include the moderate complexity ones, the low complexity, the high complexity automated machines. So that apart, you can also use a urine antigen detection test. In addition to the previous slide that we just mentioned, the biomarker-based lateral flow lipoarabinoma Amman assay test is recommended to assist in the diagnosis of TB in selected group of people. That is the HIV-infected presumptive TB patients. A positive FLAM result is considered as bacteriologically confirmed TB case. And so this test is a urine test where it comes in a cassette form. It's like a rapid diagnosis test that comes in a cassette form. Now the urine is put inside a tube that has the reagent in it. So once the urine is dropped into the tube, they allow it to stay for about, after shaking it, you allow it to stay for about 40 minutes, after which you pour it on a cassette. Then you press the reagent test. It takes about 5 minutes to read. This test is highly sensitive in patients who are severely immunocompromised or they have severe forms of the disease state. It's usually insensitive in patients who are HIV negative. And so the follow-on test, like we said, the follow-on test includes the line probe assays for the detection of the resistance of rifampicin, isoniazid fluoroquinolones, and the second-line injectables as well. So they are classified as either the low complexity automated ones and now the high complexity reverse hybridization, not for detection of PSA resistance. So initially, when we were talking, the first slide for the investigation showed that the first step used to be sputum microscopy. But now WHO has reclassified them, and the initial test for diagnosis without drug resistance TB, you can use the TB LAM assay study. And you can also use the urine, the LF LAM, the one we just spoke about in the previous slide. And so there are some benefits the LAM poses as compared to the regular PCR that we do. That one is isothermal, but the PCR requires temperature recycling. It also requires 6 primers, but the PCR requires 2 primers. That one is rapid. You can get your results in less than 30 minutes, in around 30 minutes. But the PCR, you have to get it in over an hour. The product yield is higher compared to the PCR, whose product yield is lower. But this one with visualization is also possible. The PCR, you can't visualize it. But the difficulty is that this one is difficult to multiplex. But with the PCR, that's one of the flaws with the LAM technology. And so these are the initial tests for the diagnosis of TB with drug resistance. And so we can do the common gene aspects that we know and the other flow assays to supportive investigations. We have the full blood counts where you may find an increase in the lymphocytes and a decrease in the HB as well. The liver function test where there's an elevation in the liver and serum enzymes, increased CRP, the urine creatinine may be deranged, increased ESR as well. So with the treatment of TB, the steps that we take for effective anti-TB management is one, to make a diagnosis. So we have to determine who we should treat. Make a case definition. Making a case definition, we talk about the site of the TB, the bacteriology of the person, the severity of the disease. And by so doing, we also have to ask whether this patient has ever been treated for TB or this is the first time the patient is getting TB. We also further categorize and treat the patient. But while at it, we also have to supervise and monitor our treatment to ensure that the patient completes the treatment and to prevent default. So the aim of the treatment is one, cure the patient with minimal interference to his or her life. Two, to prevent the death of active disease and its complication, prevent relapse of the disease, prevent transmission to others, and to prevent development of resistant of TB, which is more difficult to treat. So the organizational framework for the treatment employs the DOT strategy. And so management here includes both pharmacological and non-pharmacological management. So the non-pharmacological management includes counseling, nutritional support, where some of the TB programs provide food supplementations. Then also adequate rest at least 1 month from the patient's routine work and physiotherapy. Then also you need a treatment support system or enabler to help you throughout the course. That's when you employ the DOT system. And so the pharmacological system, the pharmacological management, TB treatment is usually done within 6 months. PTB treatment is usually done within 6 months using first-line drugs and second-line drugs. The first-line drugs being rifampicin, isoniazid, pyrazinamide, and intermutol. Then the second-line drugs as well as the injectables as what is being projected on this slide. And so usually when you see the medication, the medications are usually abbreviated, and these are the abbreviations they use for the first line, that of the second line. So the treatment, the mode of anti-TB drugs, the mode of action on anti-TB drugs, one, they are bactericidal drugs. Two, they are sterilizing action drugs. Then three, then some of the drugs also prevent resistance. With the bactericidal ones are the isoniazid, rifampicin, and pyrazinamide. And the sterilizing ones are the rifampicin and pyrazinamide. And prevention of resistance is isoniazid and rifampicin. So the treatment is done in 2 phases. Usually the initial phase, that's the intensive phase, and now the continuation phase. Now I usually use 3 or more drugs to treat that one to eliminate the TB bacilli and also to prevent resistance. Then the continuation phase also ensures permanent cure, prevents relapse or completion of the disease, less number of drugs, and they also should be long enough to ensure success. And so the duration for treatment of the duration for the treatment of TB, PTB, is still 6 months. So a new patient with pulmonary TB should receive a regimen containing 6 months of rifampicin. So the 2 months of the intensive phase and now the 4 months of the continuation phase is what is written. Is what is kept in the table here. which WHO still strongly recommends. Still strongly recommend. Resistant strains. Drug resistance to TB must be suspected in persons who remain bacteriological positive after intensive phase or first-line treatment, with or without any clinical improvement. So these patients who are at risk to resistant strains are people whom treatment have failed in categories 1, 2, and 3, and people who have had contact with confirmed drug-resistant TB, and people who have HIV or infections as well, patients who are coming back with relapse and return after loss of follow-up, and health workers who are newly diagnosed TB. And so in talking about resistant TB, there are certain terminologies we use. And so these are some of the definitions. Monoresistance ones, they are resistant to only one first-line drug. Rifampicin resistance, they are resistant to rifampicin with or without other first-line drugs. Polyresistant, they are resistant to at least 2 first-line drugs, but not isoniazid and rifampicin. They're multi-drug resistant, they are resistant to both pyrazinamide and rifampicin. Then extensive drug resistant TB, they are resistant to any of the fluoroquinolones, at least one injectable second-line drugs plus multi-drug resistant TB. So how do you manage people who come with isoniazid resistance TB? That one, they give a combination of rifampicin, ethambutol, pyrazinamide, and levofloxacin, which is recommended for a duration of six months. And so in the treatment of multi-drug resistant TB, we have a shorter standardized course and now the longer regimen. That may either be standardized or individual based on the patient's drug sensitivity testing. And so the short course, we do 7 drugs. That's the kanamycin, prothionamide, isoniazid, moxifloxacin, ethambutol, pyrazinamide, and rifampicin. So 4 months of the intensive phase and prolong if they are still smear positive after 4 months. Then 5 months continuation phase run for them. Okay, so in the treatment of the long-term treatment, the longer course treatment, that one you need
sorry,
at least
Dr. Raymond, sorry to interrupt, but I think some of the participants asked that you should slow down a bit for them to be able to assimilate everything.
Okay.
Thank you. So,
okay. So with the longer course treatments, that one you need at least 4 TB agents that are likely to be effective. And you need at least 3 agents that are included for the rest of the treatment after bedaquiline stopped. So they are grouped, or they are put into steps. So group A, group B, group C. So with the group A drugs, you need all 3 medications to be part. The group B drugs, you need to add 1 or both medications to it. Then with the group C, you add to complete the regimen. And when medicines from group A and B cannot be used, what we do when the patient does the drug sensitivity testing as well. And so in the monitoring of patients who are being treated for multi-drug resistant TB, the patients who are on longer regimens, you can do a monthly sputum culture for them. Also do a sputum sphere microscopy. What are the markers for response of treatment or progression? The patient's general condition, once you realize that the patient is improving, there's weight gain, there's resolution of manifestation of the disease. Look at the blood indices and they are all improving. Then your imaging results as well. Once they improve, you know that the patient is responding to the treatment of the disease. And so these are the medications that are available for treating patients with multi-drug resistant TB. So the ones that are not readily available are the bedaquilins, the linezolates, and now the delamanites. So as part of monitoring of patients with TB, like we said, for multi-drug resistant TB, also covers for drug susceptible TB as well. So with the monitoring, we also have, not just with our treatment, we also have to monitor for toxicity, since most of these drugs are toxic. You have to teach the patients to also recognize the early signs and report early. You should have to ask the patient about adverse effects or symptoms anytime they come for, or we follow them up. So they can also be grouped up minor and major side effects. And so this table just gives us some of the examples of side effects that the patients may have anytime they're on TB treatment. And so streptomycin, usually they have ototoxicity, rash as well. They also have if nerve neuritis. So that can present with deafness, dizziness, or vertigo. And so what we usually do is to stop the treatment and give a tambuto. And so thiazide 2, it can come with rash and Steven-Johnson syndrome. And we have to stop it. Then rifampicin, those ones they may present, they commonly present with orange urine. So with this one, you just reassure them. But if they start getting jaundice or elevated liver enzyme indices, we have to stop it. So with pyrazinamide, it can come with jaundice and vomiting. Then some come with bone pain or joint pain. That's associated with increased levels of the uric acid that they have. You can stop it or give it safety. And isoniazid, the cancer of peripheral neuropathy and cholestatic disease, can give them vitamin B6. Then with the tambutol, now they can come with visual impairment. So even before we start them on all these treatments, they are supposed to have an eye exam and all these things before we start them so that we know their baseline. And we can determine if the drug is causing all these visual impairments today. And so with complications, there's group that are local or systemic complications. And so they can come with massive hemoptysis, pleural effusion, tuberculosis, pneumonia, bronchiectasis, pneumothorax, or pulmonary. And the systemic ones can come with skeletal TB, gastrointestinal tuberculosis, tuberculous meningitis, and genitourinary TB, as well as tuberculosis lymphadenitis. And so usually when they come with the complications, especially the local ones, sometimes surgery is indicated. And so patients who come with massive hemoptysis, patients who have extensive destruction of their lungs, bronchiectasis, and pneumonia, and people that we suspect that they also have malignancy within the affected areas, surgery is indicated where you can do a lobectomy, bilobectomy, and pneumonectomy. But we don't usually do, but the surgeons don't usually do stage lobectomy for localized. So they do stage lobectomy for localized bilateral disease as well. But where the segmental resections are usually not allowed due to the increased risk of bronchopleural fistula as well. And so people who come with massive hemoptysis, they can also do a bronchial embolization for them. That temporarily stops the hemoptysis in which they are getting. Differential diagnosis can have pneumonia. It's usually when they present in initial stages, it could easily be a pneumonia. It could also be chronic bronchitis or COPD, bronchiectasis, asthma, bronchogenic carcinoma, lymphoma, then Hodgkin's or non-Hodgkin's lymphoma. Also have pulmonary fibrosis and silicosis. Also have associated immune suppression, such as HIV, diabetes, and chronic. So these are the reference, the short presentation of pulmonary TB. Thank you.
Great. Thank you, Dr. Atakumah, for the great presentation. Quite a fast review at it. And I'm sure a couple of us would have to sleep over it to get all the details, especially with the updates with regards to multi-drug resistant pulmonary tuberculosis. Okay, so I don't see any questions in the chat box. I would wish to ask us all to kindly click on the link that I've put in the chat box for us to review our presentations from last year and to be able to improve upon them this year. Out of the over 80 participants that we have, we currently have 35 responses. Obviously, that's way less than half of the number of us on the platform who have provided responses to this. It just takes less than 2 minutes and you would be done. It's important because it will help us to be able to, of course, evaluate what we've done and get your suggestions as well for improvement in subsequent presentations. So to be able to serve you better, it would help if you can provide us with these responses. Otherwise, it's just like the status quo. We continue with the same thing that we are doing without knowing if there are any issues that are up that we need to look at. If you do have any questions, suggestion, or any of such regards pulmonary tuberculosis, kindly put up your hand and then I would unmute you and then you can ask your question for Dr. Raymond to lead us. Any suggestion, comments? Kindly raise your hand electronically and then I could unmute you. Either Dr. Raymond has given everything that we need regards pulmonary tuberculosis, or he has 100% confused us, because I don't see any answer. Okay, great. So Bismarck's hand is up. Let me unmute him. Bismarck, please unmute yourself and go ahead.
Thank you very much for the lecture. He has really done well, though I came late, but I think the presentation is worth listening to, and it's going to help us with our clinical practices. So we are grateful for that. And but the only suggestion I have is how fast it goes. Some of us, we are very slow, so we are suggesting that those subsequent lectures that will come, you try and talk about it, let them slow down so that we can pick things up as easy as possible. This is my suggestion. Thank you.
Thank you very much, Bismarck. Well noted. And like I said, it got to a time that we needed to interrupt Dr. Raymond so that he could slow down for us to all get to the same level that he is. So well noted. Obviously, good for subsequent presentations as well. Any more? We still have about 15 minutes. If you do have any, kindly let me know. Okay, whilst we are waiting for questions, comments, suggestions, I would wish to remind us all that in the chat box, you would find a link in there that you could click on, and within a matter of a minute, provide us with your evaluation of the presentations last year, as well as even including this presentation, so that then we're able to subsequently make those changes to reflect what people want, and to be able to help us all to better understand the topics that are presented. So kindly check in the chat box, and then you could click or tap and then provide your responses. We have over 80 participants. We don't have half of the number providing us with responses. Yes, Emmanuel's hand is up. Emma, please unmute yourself and go ahead with your comment or suggestion or question.
Yeah, good afternoon to everyone. My name is Emmanuel. My question is with regards to the treatment. He has given us a list of combinations. I want to find out whether those combinations are the same for pediatric population, and how common are those medications? Because the last time I had a pediatric case, we were able to get the medication for the mother, but the child, it took us almost 3-4 days before we were able to get some. So if you can comment on that.
Great. Raymond?
Yeah. Okay, thanks for the question. Usually the medication, in all honesty, is difficult to come by. But usually with the doses, it's usually weight adjusted doses. And so they pair them with the weight based on the doses based on the weight the patients presented. I don't know how common it is. I honestly didn't go through pediatric doses, but I just know that majority of these medications are weight adjusted doses. So if the child may fall within that weight range, then the medication could also be indicated in it. I don't know how feasible it is to get for pediatric doses. That's I honestly don't know.
Great. Neither do I, Raymond. So we practice adult medicine. I'm a physician specialist. Obviously, we have pediatricians on the platform as well. Dr. Matilda, Dr. Haruna and Co. If you are present, you could unmute and let us know how easy it is to be able to get the pediatric doses. Obviously, I've seen a couple of the kids being put on anti-TB medications. I don't know specifically what formulations they have. But like Raymond rightly said, even in adults, it's not a generic thing for everyone. Ideally, it is done calculated per weight. It's not like a routine that everybody should take the same. Obviously, I weigh about 65, someone weighs over 100. It's just that for ease of administration and availability, you usually have them, the blistered ones already given mainly for a 60 kilogram average adult. So that's how it goes. For the pediatric age group, I don't know what formulations they have. Great. I don't see any hand up, but in the chat box, I think there are a couple of questions. So let's address that and then we could continue. I think the first one was asking for the presenter to slow down. I think that I interrupted and then we sorted out that. So thank you, Bismarck, for that. Then he asked about kindly share the lecture if you can. Yeah, so I would put my phone number up. You could, on Saturday, send me a message and then we can send the recording over to you. Usually it takes time for Zoom to put it up on the platform so that then we can share that. And then in the comfort of your bed, you could listen to it, pause at any time that Dr. Raymond did go fast, and then you could get the details of it. Now, Abrifa's iPhone asks relationship between pulmonary tuberculosis and low hemoglobin. Dr. Raymond, any response to that?
It's usually because of nutritional deficiency. I've not come across any paper where they've written a direct cause of TB to low hemoglobin, unless, of course, these patients are presented with massive torrential hemoptysis, or yes, basically that is it. Unless they have complications with massive hemoptysis or they have nutritional deficiency that predispose them to really getting TB. I didn't come across any lecture on that.
Okay, great. So we know tuberculosis is one of the chronic granulomatous diseases, and like any chronic disease, you can have anemia of chronic disease, and also as other than the nutrition as well. Of course, you can have this. So those are both the direct and indirect links to having a low hemoglobin and having pulmonary tuberculosis, other than other comorbidities that may result in low hemoglobin levels. Then Betty said that this is a great presentation, was fast but worthless. Kindly share the slides. Like I said, I'm just putting up the number again, and then you could pick up the recording of this meeting from it. I've just put it up. So thank you, Betty, as well. Then T.Y. Charles asks, what's the role of septrin in the treatment of pulmonary tuberculosis? Raymond, any response to that?
The role of treatment of septrin is directly linked, as I know, is directly linked to the treatment of HIV, where they give a cover for them for all the other infections that they could probably come across. But adding it to the regular TB medications, that I didn't come across.
Great. So cotrimazole, the common brand that came up, septrin, is mainly used in the OIs, the opportunistic infections, i.e. as prophylaxis. We'll give the 960 twice a day, or even in the treatment of, I think about third or fourth line in the treatment of cerebral toxoplasmosis. So these are the settings in which it's used. Like you see with the anti-tuberculosis medicines, cotrimazole was not part of those. And then, yes, and if we could have one on pediatric TB, great. Charles, I think Matilda and co would pick that up. The pediatricians would look at that. Then Aliu MD said, good afternoon. Usually patients presented with empyema thoracis are usually started on TB treatment, even when the gene expert or microscopy is negative. Why is that? Is there any evidence supporting this? And how do you follow up such a patient? Raymond, do you have any response to that?
It will be difficult to tell because the policy is to be able to try and detect TB using all the newer available ways of investigating it and treating as well. But great. I didn't come across that.
Yeah, so empyema thoracis, obviously, you'll not be started on TB treatment unless it's confirmed that it's tuberculous bacilli that is causing the empyema thoracis. Several bacteria can cause empyema thoracis, not only tuberculosis. So I don't know about any evidence supporting that as well. People do, of course, rural practice is different from evidence-based medicine where you can, but of course, we have to aspire to do things the right way. So ideally, if you have empyema thoracis, obviously you need to culture whatever that is in there. And you can start on a broad spectrum antibiotic and tailor it towards whatever the culture results do bring in. In the rural environment where sometimes there's unavailability of broad spectrum antibiotics, mind you, the combination of these four very potent antibiotics, they are antibiotics. Anyway, people will usually do that in the absence of anything. So maybe it's in that setting that they do. I don't have any evidence with regards to that. I just saw a patient at the ward today who was in at the Tamale Teaching Hospital with empyema thoracis. They did a histopath on I think they took some of the fluid as well as some lung tissue. And it did come out as caseating granuloma. And then they asked that he should come over here for start of anti-TB treatment because he's from this part of the northern belt. So obviously in the setting of that is right to do. But I don't know about everybody with empyema thoracis being given that. And he did ask, how do you follow up such a patient? So the follow-up is, as we just said, you culture the fluid, and then obviously you start broad spectrum. Depending on whatever the culture yields, you'll be able to follow up. Then Whittle, Alfred said, I'm grateful to be part of this learning session. All right, thank you, Whittle. But I guess you wanted to do thumbs up, not thumbs down. Then Dr. Ephraim Oklu said, what is the gold standard for diagnosis? Is it the gene aspect or microscopy? I think Dr. Raymond did say it, but you could highlight it again, Dr. Raymond. The gold standard for diagnosis.
The gold standard is culture of the Mycobacterium species tuberculosis. But in terms of diagnosis, I'll put gene aspects above microscopy because of the shortfalls in microscopy, where it is operator dependent and typically you need about 5,000 to 10,000 bacilli to be able to see through the microscope that this is positive for tuberculosis. But with the gene aspect, that one also gives you a further advantage that it also tests for rifampicin to see whether it is positive, it is resistant to it or not. So between the two, I'll choose gene aspect, but the gold standard is actually doing a culture.
Thank you, Raymond. Then the next one is from Andani. Please, can you combine TB medicines with antipsychotic drugs in case you have a psychiatric client diagnosed of TB at the same time? Do you have any response to that?
That's obviously, there's no yes or no answer to it. We have to look at the medication in which they are given for the psychiatric condition, then the patient's classification, the kind of TB the patient have. Then we'll look at the drug-drug interaction before we can actually go ahead to treat.
Great, fantastic. I did see Dr. Joel and a couple of other psychiatrists on. If you want to make an input on that, you could kindly put up your hand and then you can provide us with expert guidance. But I tend to agree with Raymond, obviously. There are drug-drug interactions, depending on which antipsychotic you are going to put the person on, as well as which TB anti-tuberculosis medications the person on. So it's not a generic answer to a yes or a no. Then Emmanuel asks, is there a stage where after the patient has been put on treatment, he or she will not be able to infect others? Raymond, do you want to go over that?
Obviously, when the patient has become smear negative, the likelihood of spreading the infection is reduced.
Great. So obviously, we that's why in one of your slides, I did see that the microscopy or the sputum for analysis, either by gene expert or AFB, would have to continue to confirm that this is negative. Ideally, even there's some literature backing the evidence that sometimes you may need to extend the intensive phase from 2 months to sometimes 3 months or 4 months if the sputum does not turn negative. So this obviously is all tailored towards rendering the person smear negative as early as possible. Please, Sani asks, please, is this same treatment for pulse disease as in pulmonary TB? Raymond, do you want to respond to that?
It is not same treatment regimen, but obviously patients that come with pulse disease, you have to investigate them by doing the drugs. With this, you don't usually have fixed regimens for them. Based on the drug sensitivity testing, then now they formulate a regimen for them. But even with the duration, with pulmonary TB, if they present, we treat them for 6 months. But with the duration with POTS, I think it's extended.
Yeah, so great. So obviously, there's differences in the duration, and of course, depending on the DST that is done, that's the drug susceptibility testing. You may have one regime or the other. So it's obviously not the same, Sani. Then Ayarga Eric said, wow, that's awesome. What a great presentation. God bless all organizers. You do all. Thanks. Thank you very much, Ayarga, for your positive feedback. Sani asks again, can a pulmonary TB patient who has been on treatment and completed it and tested again on gene expert turn out to be no TB detected, but patients still develop complication of lung collapse? Yeah, so obviously that's possible. One of the complications could come. You don't need to have active bacilli in there before you develop any of the complications. I think we just have under a minute to go. Only one hand is up. Cosmos, kindly unmute yourself, and then you have the last go, and then we could close the session for today. Nengdo na Cosmos, kindly unmute yourself.
Hello, okay. Hello, good evening, Doc.
Good evening.
Hello.
Please go ahead.
Okay, yes, I just want to, sorry for joining just some few minutes late, but I want to find out, somebody sent a chat concerning like how, if somebody is on, let's say you are diagnosed TB positive, and then how long will it take you before you can be infected, like you can infect other people? I didn't get the explanation very well, because I understand from one of the meetings I had with some others that it's 2 weeks if you are infected, if you are positive, and then you are on treatment for 2 weeks, you are no more infectious to other people. So I don't know whether that literature still hold. Then secondly, to the TB medication, that's why we are just viewing. I don't know whether I'm the only person viewing it. The TB medication available in Ghana, I'm thinking possibly that should be the MDR. We have the one available and then the one not available. Hello?
Okay.
Yes, we can hear you.
So like, I don't know, this to my understanding, I think they are no more fixed dose like the CAT 1 and 3. I'm not seeing betacholine and then linezolate in what we are using currently for those with the like the MDR cases. So I don't know, I'm seeing kinamycin and then capromycin, but like the 8, I think they're usually 8, they are 7. Then per doesn't making it 8, but I'm not seeing linezolate, betacholine, and some others we are using in treating the MDR cases, which is
great
available in the country. Just the slide I'm just viewing.
Yeah.
So I don't know.
All right. So so quick responses before we run up. So if one for the first question regards when you be smear negative or when you be non-infectious, human beings are not machines, and we don't have, each person is unique, and that's why each person is assessed uniquely. On the average, most people say that if you started on the intensive phase, most of the time you would within the first 2 weeks be smear negative. This doesn't hold true for everyone. And that is the reason why the National Tuberculosis Control Program does ask that you should continue with checking for smear negativity. So it is not generic and it's not cast in stone that for 2 weeks, everyone would be smear negative. And most of the times, it may not hold that as true. So obviously, you would need to follow up with the sputum for AFB to be able to confirm that the person is smear negative. And what we added in was that because of this, most of the times, if you test and it's still smear negative, even at 1 month, 2 months, sometimes you may have to extend the intensive phase. That is why, again, the National TB Control Program does recommend that when you test and it's continuously smear positive, despite on the intensive phase, you refer to see an infectious disease specialist or a physician specialist so that then they can tailor the management appropriately, because there's a level to which then you need to. The slide that you are talking to is just a generic slide looking at what is available and what is not available. You did say that you joined in late. So if you look at the previous slides, Raymond, if you can go to the slide on the MDR-TB. So you realize that the 7 you were talking about, the 7 magic number is there. Now go to the next one, where the 7 is there. Yeah, exactly. So what you were talking about is here as well, the 4 months of the intensive phase with a fixed 5-month continuation. Now, if you can go to the previous one, what you did show. Yeah, so this is the other one for the MDR-TB. So here you have your linezolid and then your clofazimine and all of those ones in there. So the slide you were looking at is just looking at what is readily available and what was not so much readily available. But even from last year, linezolid, bedaquiline, and all of that, they are readily available for MDR-TB management. I was at the National TB Control Program meeting on MDR-TB just last month, that's December. I think most of the facilities or most of the places that are allocated for MDR-TB, we do have these readily available. I'm happy the regional TB coordinator, Mr. Minta, is on the platform as well. Just yesterday, I was on a monitoring visit with him to see all our MDR-TB cases in the Upper West region. And we can report that this is readily available for use as well. So these are things that are there. And of course, you should make use of them. When you run into troubles, it's usually good to get the focal person in charge alerted. Of course, all MDR-TB is actually supposed to be multidisciplinary team approach towards the management of it. And I'm happy that those who are attending to the cases that we have in this region, really it was a team's effort. So if you do pick up any of these in your district or your region, it's good that you involve all the people so that together we prevent or we are able to treat MDR-TB and we prevent extensive drug-resistant TB and what we even fear where you may have a total drug-resistant tuberculosis. So those are the key things I just want to highlight as well. I still see there's a bit of, there are some few questions in there. We can make time to go through them. Bernard Boza said, please, can you do CS for post disease? I guess you mean culture and sensitivity. So obviously that will be difficult because if you are going to cut off the bone, post disease just means TB of the bone, is that also, or TB of the spine. So obviously that may be a bit difficult, except that once you take the sample, you would do histopathology. But obviously there are non-invasive ways of looking at it. A simple chest X-ray may show you an anterior Y-shaped collapse, which is typical for post disease. If you go ahead to do a CT scan, you may find finer details. An MRI would definitely give it away. Now, the other one is from currently available regime for MDR-TB include linezolid and bedaquiline. Exactly, this is what I've just highlighted and what the slides do talk about with regards to the use of linezolid and then the bedaquiline for treatment. So these are readily available. I don't see any hand up. initially I'd seen Nabil stand up. Nabil, if you are there, you could unmute yourself and then give us what you have, and then we can conclude.
Yeah, boss. Okay. Good afternoon, boss. Yeah, and thanks for the opportunity. I think it was a very good presentation, and I enjoyed and I learned quite a lot. I joined in a bit late, so I'm not sure if the comment I want to make was already addressed, but I wanted to initially comment on the question with regards to the infectivity of the patient after initiation of anticox. So, but I think you made a few comments regarding it. So generally, studies have shown that after 2 weeks of anticox, the patients usually are not infectious. But it doesn't mean you don't continue to test for the TB in the course of the treatment. And usually this is for the purpose of deciding whether some of these patients should be isolated or can be managed on the general ward and all of that. So there's always that fear on the parts of clinicians whenever they are dealing with patients with pulmonary TB, and then there's the fear of avoiding contact, isolating them completely, and all of that. So we know for a fact that generally, after 2 weeks of anticox, most patients are not infectious, and therefore it allows us to probably allow them to be on the general medical ward, especially in places where we don't have the infrastructure to keep all patients at the infectious disease department. And so I just wanted to comment on that, but you had already addressed it. And I wanted to find out if, I don't know if the presenter spoke about it before I joined, but in terms of TB diagnosis, the use of the urine lamp, I don't know if he spoke about, especially in patients who have HIV co-infection.
Yeah, I think he did that. You can just get back to, he did justice to that one and did highlight the fact that it was of importance. Okay, that's it. Sensitivity poor in those who are negative, and of course, I am aware of I don't know if they finished that trial. There was this project that a white lady was doing with the infectious disease unit, the fevers unit at Kolibo Hospital with Dr. Popolampo. They were using the urinary lamp.
She's still around. I'm not sure if she's done with the project, but we see her around every now and then. So I'm not sure if they are done or it's still being run.
Great.
But I mean, if it's possible for us to get these kits up north, probably it would help a lot. I know.
Yeah, definitely. I'll probably find out from the lab guys whether these are available. And good enough, Mr. Mintawi is the regional TB coordinator is on. So I'll probably let him provide responses to that as well if he has knowledge of such.
Okay. Thank you. And I'm glad the presenter actually spoke about it. I think I joined after he discussed it. Thank you very much.
Thanks a lot, Nabil. Great. Mr. Minta, so kindly lead us on.
All right. Good afternoon, everyone.
Good afternoon.
Thank you. My name is Minta. I think concerning what Dr. Nabil just asked, in fact, I don't have a response to that. There is no information on whether that is available or not. So my concern is actually to address a concern by someone about the availability of the medicines, the pediatric medicines. Yeah. So the medicines are readily available. I think the person recall an incident where they needed it, but had to delay for some days and all that. Secondly, sometimes there may be some level of shortages here and there, but I want to emphasize that it has always been readily available. And also concerning whether there is the same formulation with the adult. In fact, there is a bit of slight adjustment. So it's not just like because it is weight-based, the pediatric one is just a reduced form of what the adult formulation entails. There's a bit of small adjustment with the combination and then all that. But I want to say that it's pre-packed and is available only in public institutions What I mean is that you won't get the kit, pre-packed kit available on the market. You may have some loose component of it, depending on what someone needs it for. But then for a kit as a regimen for TB treatment, you can only get it through the health service. Thank you very much.
Yeah. Great. Thank you so much. And of course, I think that just sums up everything.
Hello, Doc.
Yes, please go ahead.
This Cosmos, I just want to clear something for myself. Yes, I think before 2014, there about like the reinfection, the relapse cases. I think they used to give them some like step-2 injection and then increase the intensive phase to 3 months. But I think somewhere along the line, the program conducted some survey and realized that it is no more effective. But I don't know. Whether as of now, as stand now, things have been changing. So those relapse cases we are having, are we still going by like the normal cut 1 and 3, like where we have the 2 months intensive and then 4 months continuation, or we still have to go by the 3 months intensive and then extend the other one to so making around 7 months, sorry, 8 months?
Okay, great. So I'll let Mr. Minta answer that from the National TB Program guidelines.
All right, thank you very much once again. So, of course, the duration for retreatment has been 6 months, as we do for the new cases, okay? So we don't have anything like extension by 1 month for intensive phase, and then the continuation phase 2, making a total of 8 months. But then, as you may have learned from this presentation, sometimes treatment could be extended based on the type of infection and then all that. For example, when it is pot disease, there could be the discretion of extending the duration even up to sometimes 10 months or even longer. So that becomes an individualized regimen sort of. But then with the just retreatment and the new case, the duration is 6 months for all.
Okay,
Great.
a very big one, my boss. Doctor, like the policy we are talking of, mostly like when we get them, I don't know exactly which area, is it of the spine or which area that will extend the duration for the 9. I think 2012 booklet for the program, the same relative of the spine, we need to expand to like the treatment to 9 months. But I don't know. I think they have been reviewed several. I don't know, well, like those of the like the pod disease, if it's actually of the spine, or which area are we going to extend like the extrapulmonary to, like ahead of the normal infection of the lungs duration? I don't know whether you are getting me right, sir.
Yeah, we got you 100% right.
Okay.
Yeah, so it's good that you've actually brought this up, because even during my residency training, I was asked on a general ward round about treatment for extrapulmonary TB. I still remember that day. My very own boss, Dr. Popolampo, who is the National Infectious Disease guy, laughed at me when I gave my response. So actually, it's a very simple thing. All extrapulmonary TB plus pulmonary tuberculosis, except only 2 of them, TB of the brain, TB of the bone. All the others are 6 months. So whether it is TB pericarditis, TB whatever, TB of the gut, except those 2, bone, brain, the rest are all 6 months. That's the new protocol. So of course, the bone is what we are calling pot disease, after the guy who probably discovered it. And then, of course, the brain is TB meningitis, TBM. And then tuberculoma, of course, tuberculous nodule in the brain. So any TB of those 2 parts that I've mentioned, obviously will warrant an extended duration. This one I was asking, I think that patient had TB pericarditis. And I confidently said it was supposed to be an extended this, and he laughed at me. And then later on, he shared the guidelines with me. So those are the things.
So up to what period, like the TB of the bone or the brain, like how long?
So again, it's not cast in stone. There are what do you call it? Averages that you look at. But like we said, you would obviously the first thing is that if someone has surge, it would be good to probably refer him to a secondary center, so that then you can have a multidisciplinary team approach. Because obviously this person with TB post disease would need physiotherapy. Sometimes they may even need some steroids and all of that. So where you can have that kind of multidisciplinary approach, it would be better. Now, with regards to the duration from the program itself, you realize that they don't put a specific, say, what do you call it? Say 2 months or so. So it's usually said that it's a longer duration of therapy, 9 to 12 months. This is guided by, like we said, how much of the intensive phase will need to be done and how much of the continuation phase will need to be done. Sometimes the treatment can even be continued for about 18 to 24 months. So like I said, it will be difficult to just say every patient with port disease put on this duration of treatment. Do you get it? So obviously it will depend on the regime you are using, and then it will also depend on the what do you call it, what is warranted for the patient. You get the point, and other comorbidities as well. So all these are part of it. Any further questions, please? You're welcome. All right. So we are grateful for everyone who has joined us. Again, I would wish to say that kindly check in the chat box if you haven't been able to provide us with some responses to look at our output for 2021 and looking at what we can do better in 2022. Just before we sign off, I'm going to put up the link again so that we can provide those responses. They are extremely important to us because it helps us to be able to know what we are doing and then how far we have come and what we need to do to get the presentation better at it. It only takes less than 2 minutes. So kindly do that. I've put up the link again if you have not, so that then we can get those responses and improve upon the presentation. On behalf of everyone, I'd wish to thank Dr. Atakumah Raymond for the fantastic job done. He's really highlighted a lot of things about pulmonary tuberculosis for all of us to get to understand how it is supposed to be managed. Obviously, it's a very common thing in and around us. And the fact that we need to be able to manage it appropriately so that we don't get people developing secondarily MDR-TB and then possibly even getting into extreme drug resistance or total drug resistance where we cannot do anything. So without much, I would say that thank you, Dr. Raymond, for the brilliant job. We've learned a lot and God bless you. Thank you all for joining us as well. Next week, we would have another presentation. You see it on the various platforms advertised as well. So do make time with us next week. Until then, please stay safe and take very good care of yourself. COVID is real. Let's protect ourselves. Get vaccinated if you have not taken the vaccine. Thank you and bye-bye.